Really said, we remember the times that we spent in the ICU of Alleppey Medical College. Thankful for, holding my hand in this wonderful field. And thank you for the Trivandrum Medical College Alumni Association. We started thrombolytic therapy here back in 1988. It's a long story at that time. It 86 good, and that's the project that we started. It's a long story. Shiva knows it very well. It is always, such a proud moment for me to come back to this august audience. I thank the Alumni Association, Dr. John Panikar, Vasudevan sir, for inviting me and giving this opportunity. So we are talking about this aging rusty pipes. So this is the pipe supply, the plumbing work. We may think that of a third world country, but no. This is actually in Detroit, Michigan, in actually United States. It was a huge controversy how the lead leach into the water and cause problems for lead poisoning in the young people there. This is not too far away. The recent controversy that happened there. Exactly similar kind of thing can happen to our blood vessels. And this is a badly atherosclerotic aorta, as you see. So atherosclerosis is really bad. It can affect all vascular bed of the coronary arteries, of the cerebral arteries, peripheral vasculature. It can affect the aortic valve. It can cause aortic stenosis. So all these things can lead on to a huge disease burden. So as any case, we'll start with a classic patient of atherosclerotic vascular disease, past middle age, multiple risk factors presenting with angina and claudication, and got all the classic risk factors, and he cannot tolerate statin because of terrible muscle pains. Physical examination was classic of multiple bruits and diminished pulses. ECG and echo are unremarkable. Lo and behold, the primary care physician has already done a calcium score for this patient. We'll talk whether it is appropriate or not, but he comes with this heavy calcification in the coronary arteries. You can see that this is the left main stem, and this is circumflex. This is the left-handed descending artery, and this orange structure, of course, is the vertebra. And here, the densities looks like exactly the same because of the calcium deposition. And the calcium score, if you calculate here, come to close to around 3,000, really high. So, and this was a CT angiogram of the neck vessels. You can see that left common carotid almost completely occluded there, left vertebral occluded there. There is subclavian stenosis, and also right internal carotid has got occlusion there. So it's just basically the circle of Willis is maintained mainly by that one vertebral artery. And this is his peripheral vasculature, and you can see that bifurcation disease and the SFA stenosis, and you can see that almost coming on to Lerish. And this is, of course, in a money shot. You can see a pinhole meatus of the left main stem coronary artery. So this is the classic situation of atherosclerosis. So there is an oxymoron in my heading saying aging rusty pipes. So this is the data from Korean War veterans in the 50s, the autopsy series, with a mean age of 22 years. And you have got more than 3/4 of them has significant atherosclerotic vascular disease in the coronary arteries. And we know that it is an age-old disease. It's very, very old. And these two guys, Virchow and Rokitansky, quarreled quite a bit how and why atherosclerosis occurs, inflammations versus degeneration. Now we know it is mainly inflammation with lipids playing a very central role. That picture that is shown here is actually a specimen from Rokitansky from the 19th century. They have stained and shown that it is actually inflammatory mediated by immune histochemical stains. So it's a major healthcare burden. Long-term decline in ASCVD has been happening in the Western countries that has stalled. By 2035, half the people will have ASCVD and north of $1 trillion. But more importantly for us, over 80% of the global CVD burden happens in low and middle income countries. This is what, again, yesterday we were sitting around in a round table and talking with Mohan and San and the rest of the people. What are the opportunities for research? We have plenty of opportunity in our population to do this kind of research and find out now what exactly make us tick with coronary disease. The management, of course, the lifestyle change is the foundation. lipid lowering is the cornerstone, along with management of three other main risk factors: smoking, hypertension, and diabetes mellitus. So still, I will just focus on lipids. We know the other risk factors, and the focus of the day. We moved away from the cholesterol numbers to intensity of statin therapy in 2013 ACCHA guideline, and that has been modified in 2018 and just 2 days ago. The United States Preventive Task Force recommendation just came out day before yesterday. Similarly, it is a little bit, I don't want to go into controversies, but similar. The recommendation is similar. Intimidating picture, but we will just dump it down to 4 statin benefit groups. Number 1, individuals with clinical atherosclerotic cardiovascular disease. They need high intensity statin therapy, no question. So if somebody has an established disease, high intensity statin. Number 2, if they don't have ASCVD, then you look at the primary target, that is a bad cholesterol, the LDL. If it is more than or equal to 190, high intensity statin. If these 2 things are not there, and the person is above 40 and below 75 years of age, then you see whether the person is a diabetic. And the LDL is, is at least modestly elevated above 70, then that person needs statin therapy. And last group is a number 4, that is where you don't have any of the first 3. Then you whip up your smartphone and take this app, the ASCVD Risk Calculator app. You will get it in any of your smartphones and plug in the numbers. The age, sex, and all the risk factors, blood pressure, cholesterol, history of diabetes, history of smoking, and you churn out a number. And that number in this case is 7.6%, as per the current guideline recommendation, with some changes which has been introduced by the USPSTF. I won't go into that. More than 7.5, you should start the patient on a statin, but with a detailed discussion with the patient what you are going to embark on. Because mind you, this is going to be a lifelong treatment that you are going to give. This is not a 2-week therapy that you give and then be done with. So the potential risk reduction you have to discuss in detail. We have to talk about what are the side effects that could be there. Other risk factor management is very, very important. You utilize that time to establish a relation with the patient and explain all those things. And still, the decision is not very clear. Then you have other means like calcium score or high sensitivity CRP or angle Beckel index or carotid intramedullary thickness. All these things you can utilize if the person's risk profile is just below 7.5. You don't know whether to start statin. You do bring in all the other things into the picture, including family history, and then make a decision in discussion with the patient whether he should be put on a long-term statin therapy or not. So the calcium score is a very objective thing in this tool. We can really know anatomically what is happening. So it should not be done for a 28-year-old female coming to you with a chest pain. There is no point in doing a calcium score. And absolutely there is no point in doing calcium score in the patient I told you. Is multiple risk factors, classic symptom, there is no point in doing calcium score. So you should do calcium score in people who are intermediate risk, you're not very sure, and then you can start the patient on appropriate lipid lowering therapy. And the gradation of calcium score will be, 0 is normal. Of course, below 100 is low risk, 100 to 400 is moderate. Above 400, there is a risk of significant atherosclerotic vascular disease in that person, and you have to be more aggressive with them. Now, take a calcium score separately from the conventional risk factors. So you take about this, again, 65-year-old man who has got a high calcium score but no risk factors. On the other hand, you have got another 65-year-old man who has got multiple risk factors but 0 calcium score. How are they going to fare? And this was actually done as a population study from UCLA, Budoff and all. The basic takeaway is that if the individual has got high calcium score, more than 400, and no risk factors, they had a substantially more mortality rate compared to those with more than 2 risk factors and 0 calcium score. So if you have got risk factors and calcium score, that is the worst. But if you are asking about calcium score versus risk factors, probably no calcium is probably the better indicator. So we have to probably move away from the traditional risk assessment of multiple risk factors alone, but not totally, but this is a one good thought. For example, somebody is coming to you, multiple risk factors, I don't want any statin, so you recommend them based on the pooled cohort equation. But if the person doesn't want it, you can do a calcium score. If it is a middle-aged person and zero calcium, probably, he may not have very additional benefit from it if the person doesn't want to take statins. So the medications, starting from over 30 years, we have various statins showing benefits. And also statins have shown to be anti-inflammatory by showing benefits in patients with the elevated C-reactive protein. And ezetimibe and hypertriglyceridemia with icosapent and ethyl. And this is a new enzymatic preparation, that is bempedoic acid, which is an enzyme, ATP citrate lyase that upstream to the HMG coenzyme A reductase, that is actually statins. All these are newer medications that will help us reduce cholesterol. But whether we have outcome benefit, that is an important question that we have now with ezetimibe only after almost 30 years of no statin, other than statin, we didn't have any other medications actually. So anti-inflammatory drug, canakinumab, is another one that has shown to have some improvement, but it is not being used clinically. I'm just mentioning this because there's a lot of discussion about chelation therapy. I'm just mentioning there is no guideline recommendation for chelation therapy. It has shown some benefit in patients who are diabetic with the prior myocardial infarction, but ACC/AHA has not taken any position. There is a TAG2 trial is going on. Once the results out, only something will be told about that. The most important development that has happened in the past decade in clinical practice of lipid management is PCSK9 inhibitors. This monoclonal antibody, that is Paul Ehrlich, who got the Nobel Prize for immunology. We are talking about immunology here, so you can see on the left-hand side LDL receptors on the surface of hepatocytes. They actually get degraded by the PCSK9 enzyme. LDL cannot enter, cholesterol goes up, and you inhibit that enzyme, everything looks very good. Excellent results by Fourier trial, that is Evolocumab, Repatha, it is available in India also now. Alirocumab, both these things reduce cholesterol very significantly, and also it reduces outcomes. This is a newer one. This is lipase inhibition, angiopoietin-like 3 factor. So that is called evinacumab. And these trials have now focused on to the real villain in atherosclerotic vascular disease, that is Lp(a). So Lp(a) is the cornerstone and it's a real villain in multiple pathways through thrombogenesis and atherogenesis. It is a very, very highly atherogenic lipoprotein. It's an LDL moiety attached to ApoA to a disulfide link. Both Repatha and alirocumab, the PCSK9 inhibitors, reduce the levels of Lp(a), and through which it reduces the outcomes. It is very important for South Asians like us. So there is a lot of trials going on with the nice names like Masala, Sathi, Sath. Why in Asians there is increased risk of atherosclerotic vascular disease in the heart trial by Salim Yusuf, and it was known for a long time from Dr. Inas from 1992. And now ACC/AHA has come out with a position statement over the a couple of years ago, what are the risk factors and how to deal with atherosclerotic risk, especially high in South Asians. And again, focus turns around ApoA. So ApoA, the importance of ApoA is that it is not changed much by our lifestyle, exercise, diet, or nothing. It is closely linked to our genes. So that is the most important thing in the lipid management currently. So the Lp(a), the high Lp(a), South Asians in many studies have shown have relatively higher Lp(a) levels compared to the rest of the population. And there are some controversies regarding that. Some people say no. But by and large, the majority opinion is that Lp(a) is actually probably higher in South Asian population, and which is actually through which it mediates our unique susceptibility to atherosclerotic vascular disease. So this genetic variant study clearly showed that Lp(a) variants are associated with the high Lp(a), and that increases the risk of coronary disease. This is where youngsters, you are at the beginning of a dawn of a new era here. And I really envy you how you'll be practicing medicine coming into the next decade of cardiovascular disease. So this is in 1998, Craig Mello from University of Massachusetts and Andrew Fire from Stanford discovered the short interfering RNA, and they got the Nobel Prize in 2006 for that. And that is already now we have, I used it over the last 3 months, I'm using this drug, inclisiran. This is a short interfering RNA which inhibits PCSK9 enzymes and durably reduces cholesterol level. You just one injection in 6 months. So it keeps the cholesterol down. This is another one. This is a different technology. This is an antisense oligonucleotide pelicarsen. This also reduces LPA, selectively reduces LPA. Inclisiran reduces LDL and LPA, but this one reduces LPA. So another one is olpasiran, another short interfering RNA molecule. It actually just published the phase 1 trial. Already Amgen has announced that phase 2 results are actually very, very promising. So it will soon will be going within a year or two for FDA approval for this one also. The other one from JAMA, that is just 2 months ago, single ascending dose study of short interfering RNA SLN360. So all these molecules can be very, very infrequently given. That's the importance of the compliance. And that is the importance for us because of the LPA and the South Asian population. And this was actually the biggest of all, winning 2010, the gene editing CRISPR, Emmanuel Charpentier and Jennifer Doudna from UC Berkeley and also from Max Planck Institute in Germany. This is the first time 2 ladies are together getting Nobel Prize in Science for the first time. And this is huge. And the way we practice various diseases will change with this. And we are talking about a heart disease vaccine now. This was a Nature article as a rhetorical question they were asking. But soon, the CRISPR editing showed PCSK9 lowered cholesterol in primates. And now we are taking it in the patients in New Zealand. The study started last week. Even when we are actually flying this high, we have to come down also, like Polipil. Actually, we try to use Polipil modulating multiple risk factors. This is Dr. Salim Yusuf's study last year. And this Polipil, that is the initial was in the primary prevention. The secondary prevention study was published yesterday in New England Journal of Medicine, showing benefit in patients with prior myocardial infarction. So, in summary, atherosclerotic vascular disease is essentially an inflammatory disease. And lifestyle change is the key. There is no getting away from it. So you're not going to sit in your couch and get some vaccine and escape from it. So statins are the mainstay, and other agents, PCSK9 is already here, and spectacular genetic manipulations are already emerging, especially targeting LPA. Comprehensive approach is exceedingly important. I will just come back to our patient finally. So this patient, of course, was a very high risk for surgery. He had a balloon and stent into the mainstem, and he's on PCSK9 inhibitors, and he's doing quite well without any stroke or anything. And that one vessel is taking care of his cerebral circulation as well as peripheral vasculature. No problems in 3 years. Doing very well. Thank you so much for the opportunity. Thank you very much, sir.
Thank you, Najib, for an excellent presentation and taking us through the various therapeutic options that are available to us now. Earlier, with dyslipidemias, we only had statins, and we never identified even though we identified lipoprotein little a. I think the first time I started hearing about lipoprotein little a was when Dr. Enas came down. The first study that Enas presented, where he showed that the South Asians in the US had a much higher prevalence of coronary artery disease. And that paved the way for this thing. And then he clearly said that lipoprotein little a was the villain. But unfortunately, we never had any drugs specifically targeting lipoprotein little a, and we are only targeting with statins. So I think these are all new developments. The other thing, what you said is the vaccine. Probably if you can develop a vaccine, that may also go a long way to prevent. What we need to understand is prevention and not treatment is the way forward
Correct.
for atherosclerotic vascular disease. There is no other way. I think any questions from the audience, any comments or questions from the audience? Titus?
No, no. You are right, sir. The ratio of APO B and APO AI, that is the ratio. And APO A in itself is also a strongly atherogenic if you look at the molecular mechanisms, how it acts. It's a clinical association of APO B and APO AI ratio that is important. But if you mechanistically, if you look at it, it's APO A is very, very important. And the vaccine, it's not actually a vaccine. This is just once in a lifetime infusion of CRISPR. That once in a lifetime infusion will actually fix the cholesterol levels. So that's what Shekhar Kadiresan, actually the Varu Therapeutics CEO, who is a cardiologist, Mass General, is proposing. It is why I said this thing, and even though it looks very high funda for us, if we can bring it actually, if we look at the compliance, our population, if you can think about something that we can affordable and give it to the population just once, and it will be huge. So that is where we want our youngsters molecular mechanism to develop, and then we can give it in a affordable fashion to all of us. We start looking, this is one very important question that you're asking, because standardization is extremely important. That is one of the problems that we have here. So I ask all the biochemists here, including my sister, maybe, they should all standardize how you measure LPA. Routinely, it is not measured in the US now. It is almost routinely, at least in the younger people, we do measure LPA routinely. The reason, as I said, there is nothing to do. What do you do after looking at it? There is nothing to do. But now we have. Now, and things will be changing, very dramatically changing.
I think the last comment, yes.
Sir, just one question. Thank you, sir, for that
Yeah.
talk. We are prescribing, a lot of doctors, including me, are prescribing vitamin D left and right without even checking the vitamin D levels. So
No data for absolutely no data. Absolutely no data.
no data that they prospect.
No,
Thank you.
nothing.
Excellent presentation. Thank you very much.
Yeah.
Now my question is that you said on statin therapy is started. It is permanent and lifelong. Suppose I take statin and my cholesterol was or so, and during a course of time, maybe after 6 months, maybe it's coming down to maybe 190, 140. And I without what do you think of stopping?
No, the one thing, nothing is written in stone here. I mean, statin is meant to be long term, that's correct. But if it is bothering you so much, we can cut back on the dose. We can change it into another statin and then see if it is relieving your symptoms. But the other thing is more important. You are not going to reduce the statin just because your cholesterol dropped. You should not. You should keep on it. And the idea is actually for long term. Keeping cholesterol down for a few months is not going to change your atherosclerotic profile at all. So keep on it. That is what actually 2013 changed. That's why I said we are not looking at the numbers, we are looking at the intensity of statin therapy. That has to be very clear. That is what the task force, that is what they're promoting, is that use intensity of either high intensity or moderate intensity statin. Use that initial, that 4 group I said to start the therapy and then maintain it. Depending upon the patient's tolerability, you may want to change it. That's a different thing, but not based on the cholesterol numbers. You want to, if at all, there are other guidelines to go more higher, adding other things, like all the things I said, but nothing to just pull back on the statin, just based on the numbers alone. But based on symptom, you might do. Side effect, you may do. But other than that, just keep on it. That's what it is, yeah.
Lastly, I am a surgeon, but I have seen that mostly we are blaming cholesterol unnecessarily. It is an essential brick of the bodybuilders. And when is the fact that 20% of only diet contributes? The rest is manufactured in liver. So what about all these diet restrictions?
It's a big topic to talk about it. I know where it is coming from, especially the egg controversy and all. But it is very important. One thing I will just tell you: excessive cholesterol. Taking an egg a day, including yolk, it's not a problem. It's not a problem. But the thing is, excessive, it is a problem, and calories are more of a problem.
Exactly.
If you have higher calorie, that will get converted. So the egg controversy, I will just tell this much. If you take an egg a day, that's fine, but don't keep on eating egg. It will definitely, it is bad if you are going to take the egg yolk. Egg white, any amount you can take, no problem. Any amount of egg white you can take, no problems.
Good luck.
I just needed to say that just before concluding, the last sentence is all that Najib talked. I think Sri Shiva Shankaran will agree with me that the target population who should look at is from the age 25 to 35. Because there is no point the older age group going after all this. This is for the younger generation, because if you want to prevent cardiovascular disease or any vascular disease, you please start. Have your lipids checked, your blood pressure checked, and your lifestyle change from the age of 25. Not at the age of 45, 50. You look at Dr. Shiva Shankaran.
Exactly. No, we missed this talk yesterday.
No, that's true. No, I'm giving a general advice, because we always look at people who come with a established vascular disease.
It's
We
already
need
late.
to change our ideas. We need to go back earlier and start preventing earlier.
Yeah, exactly.
I have one question. So, Dr. Najib, you said we are moving away from the treat to target approach in terms of LDL numbers. Can it be applied to patients with diabetes? Because our endocrine guidelines still.
That's precisely, and I forgot that Nisha is here. So endocrine guidelines actually are more stricter. So they want it really low. I mean, the multiple high-risk patients, they want the LDL to be below 55. So what I meant to say was, we did not have, what will you give? If you give 80 milligram atorvastatin and still your LDL is high, previously, in 2013, we did not have. Now we have PCSK9. If it is above 70, you give PCSK9 to bring it below 70. For that, it is useful. So use the number to drive it down further. Don't use the number to release the, take off the pedal. That you don't do it. So if it is a high-risk person, use that actually to intensify a lipid-lowering therapy with the ones that you know that outcomes are changed. The ones that we know are actually the ones I mentioned about. Now, basically, it is LDL reduction by statins plus PCSK9 and little bit maybe ezetimibe and maybe icosapent and detail, but the big ticket items are these two. And endocrinologists it's extremely important in diabetics and those with CKD and PAD. Yeah.
The last sentence is the Lipid Association of India. For the Lipid Association of India, the target LDL for high risk, extremely high risk patients is 30 milligram of LDL. It is far lower than what the Americans have said.
Correct.
So I just wanted to conclude with that. Thank you, Najib, for an excellent session. We all enjoyed it. Thank you.
Thank you. Thank you. I mentioned, yeah. Yeah, yes. Nextly told, yes.
We request the chairperson to hand over the certificate of appreciation to the speaker, Dr. Najib Usman. We request Dr. Matthew Thomas to hand over a certificate of appreciation to the chairperson, Dr. Venugopal K. Volunteer.